Welcome back to another episode of Oncology for the Inquisitive Mind, where we continue on our ASCO 2025 sojourn. So this is our second episode in the GU, genitourinary space, and we're happy to have one of our regulars back on the show, Dr. Enrique Grande. So I'll go a bit through his history and then we might hit the ground running. So Enrique is the head of the medical oncology program at MD Anderson in Madrid and was one of the clinical research leads there as well. His primary focus is on genitourinary and endocrine tumors, and he's done a heap of really fascinating stuff where there's a previous episode which you should definitely listen to when we spoke to him. I think it was last year now. But Enrico, thank you so much for coming back on the show to give us your insights on GU cancers, specifically bladder. How are you?
I'm very good. I'm very happy, and always your invitation is very well welcome from my side.
Thank you. Michael, do you want to hit with the first question?
Absolutely. So, a bit of a slower day, a slower ASCO 2025, perhaps compared to years past. Enrique, you mentioned that before we started recording, and we've heard that from other people in the GU space as well. But nevertheless, I'm sure there was still things that got you excited. So, in your opinion, in sort of areas of bladder and kidney cancer specifically, was there anything that got you excited about how a particular paper might change our practice, might improve our practice, even in a small way, even if it was just a refinement of what we already do?
Hi, Michael. Great to see you as well. And probably this ASCO has not been the most exciting one in terms of genitourinary tumors new data, but there was a phase 3 trial that definitely is practice changing, which is the AMPLITUDE. The AMPLITUDE trial is a phase 3 pivotal registration trial for the combination of niraparib plus abiraterone and prednisone for patients with metastatic castration-sensitive prostate cancer, particularly for those patients with HRR alterations, and of course always led by the huge activity in patients with BRCA1 and BRCA2 tumors. Well, probably this is practice changing because the trial was positive in terms of the primary outcome for the radiographic progression-free survival versus standard abiraterone plus prednisone plus ADT treatment. So I think this is probably it will get the approval because this is positive for the primary endpoint. This is not really impacting in the overall survival so far. Probably longer follow-up is needed, but because the treatment is given in so early a stage of the disease, and we have at least 3-4 options that in later lines can improve the survival, I think we will not be fair if we are demanding for overall survival improvement at this stage of the disease, in the metastatic hormone-sensitive, castration-sensitive prostate cancer. So this is the real practice-changing trial that we saw. Very exciting about this data. And in kidney and bladder, well, we have seen different data, not really changing the practice, but definitely adding some value or reinforcing what we are doing in daily practice, Mike.
And what sort of reinforcement data was there at ASCO in kidney and bladder? Because obviously, I think the last major meeting at ESMO last year, that was when NIAGARA came out and sort of surprised the world, as it were. But what sort of stuff was in the kidney and bladder space that caught your eye?
Well, I think more data came from the bladder cancer field. EV-pembro has been established as the standard of care in the first line metastatic urothelial carcinoma, and Shilpa Gupta presented some very, very nice data about what it was the outcome for those patients who responded to EV-pembro strategy, particularly for the 30% of patients who achieve a complete radiological response by RECIST criteria. At least 3/4 of the patients were still maintaining the response, keeping the response after 2 years of follow-up. Can we start to talk about if these patients are cured or not? Well, we will see with a longer follow-up, but definitely this is a very, very relevant clinical data, clinical insights. However, there were 2 posters, not really with a high impact, at least because that were presented as a poster, that I think it is really important from our daily practice perspective. The first one is coming from the Memorial Sloan Kettering Cancer Group. Jonathan Rosenberg led a study in which I think they treated, or they saw the outcome of around, if I am not reminding correctly, 46 patients treated with platinum-based chemotherapy when patients progressed to EV-pembro in first line. And the responses they saw were in the range of 50%, no matter if patients receive GemCarbo or GemCis after EVP. Why these data are important is because so far we didn't really have relevant data or significant data of what it was the best treatment approach for patients relapsing to EVP. In the EV302 trial, unfortunately, we didn't see this subgroup analysis of what patients receive in later lines of treatment and what it was the outcome. And for the first time in a serious series coming from the Memorial, we have a strong, let's say, a robust data coming from the real world, stating that GemCarbo, GemCis can be a good option for patients relapsing to EVP. On top of the 50% of responses, which I think it is pretty good, platinum-based chemotherapy can rescue patients progressing to EVP. We can also say that the median progression-free survival was in the range of 5 to 6 months, this is not that far from what we have with platinum-based chemotherapy in the first line. So probably, and this is just hypothesis generating, probably platinum-based chemotherapy can rescue patients treated with taxane-based chemotherapy, which this is enfortumab vedotin. So this poster for me, this is important and relevant from daily practice. The second poster is coming from the Joachim Belmont's group at Dana-Farber in Boston. And they did a retrospective analysis of the outcome of patients treated in their institution at Dana-Farber, of patients with non-urothelial variants, histologies, treated with EVP. And the results were extremely insightful, because the responses they had with EVP in first-line metastatic urothelial carcinoma, particularly with a squamous tumor or adenocarcinomas of the bladder, were in between 0% and 16% only, 1/6, which is completely different from the outcome in patients with transitional urothelial histologies, up to 57-60% of the patients responding. This is because of the histology, probably. This is because of the prognosis, probably it is impacting, but probably it is also because of the lack of expression of Nectin-4 in variant histologies. And this is the main question that is arising from this work, this piece of work from the Dana-Farber guys. Probably the reason behind the lack of activity of EVP in non-variants, in variant histologies different than urothelial tumors, is driven because of the lack of expression of Nectin-4. I think these two posters were really relevant for daily practice. JAVELIN MEDLEY, if the association of sacituzumab govitecan, another antibody-drug conjugate targeting TROP2, and the payload at this time is a topoisomerase 1, plus avelumab in the maintenance scenario, was compared in a phase 2 randomized trial against avelumab maintenance. The hazard ratio for PFS was 0.49, amazing. The median PFS was 11 point something months, that compared definitely very favorably against only around 3 months with avelumab single agent. So I think there is a kind of synergism. However, there was no impact in the overall survival. If you are using enfortumab vedotin after avelumab, the overall survival will be good, because enfortumab vedotin can rescue patients progressing to platinum-based chemotherapy followed by avelumab maintenance. And also the toxicity was very high. Neutropenia, febrile neutropenia, diarrhea, mucositis were adverse events related, most of them to sacituzumab govitecan, that for a for a maintenance scenario, I think this is something difficult to support. In the maintenance setting, you want to preserve the quality of life. You already obtain the response, so you want to consolidate to keep the response as long as you want, as you can, with the better safety profile that you may offer to your patients. There was a phase 3 trial presented, the CHECKMATE 901, the primary study of the CHECKMATE 901. We know that the CHECKMATE 901 was positive because in the cisplatin eligible population, the triplet of GEM-Cs Nivo is impacting in survival versus GEM-Cs. However, Michael, the primary study was Nivo-IPI versus platinum-based chemotherapy. One of the endpoints, the primary endpoints, was Nivo-IPI versus GEM-Carbo in the cisplatin ineligible population. And it was a real shame because the hazard ratio was 0.79 for survival. The Kaplan-Meier curve for survival is extremely nice to see, because you can see, as it happens with immunotherapy in I think all solid tumors, at the very beginning of the curve, you don't see any differences at all. Probably even there are more deaths in the immunotherapy arm. But in the long term, there is a very nice plateau of around 23-25% of the patients that are really long-lasting survivors. The shame is that we still don't have a good and reliable biomarker that we can predict in advance, we can select in advance those patients that will be those with really long-lasting survival. This is a shame that we don't have this biomarker. Definitely PD-L1 is not the right biomarker. The co-primary endpoint was the overall survival in the intention to treat population for PD-L1 positive patients. Once again, the hazard ratio was 0.8, very nice graph, but not statistically significant. Unless we can identify, we can see this biomarker, we will not be able to use it only immune-based chemotherapy, immune-based immunotherapy to our patients in daily practice. You mentioned the NIAGARA. NIAGARA has changed the landscape in the perioperative treatment. So GEM-Cs Durva, followed by adjuvant Durva, post-cystectomy is the current standard of care. We saw very nice data coming from the circulating tumor DNA. What can we expect from that? Definitely circulating tumor DNA is prognostic. So patients with negative circulating tumor DNA, they have the best prognosis. Patients with positive circulating tumor DNA, well, unfortunately, you can expect sooner than later a relapse from the local disease. If this is something that may help us in the future to avoid cystectomies or to avoid the adjuvant part, the adjuvant durvalumab part of the scheme, this is something that we still need to see. If the patient before the cystectomy, just before the cystectomy, has ctDNA negative, half of them will have pathological complete responses. But if the patient has a ctDNA positive before the cystectomy, almost no patients with complete responses, pathological complete responses, will be seen. So we still need to see what is the real value, the real role of ctDNA in daily clinical practice. Other small phase 2 trials in the neoadjuvant scenario were presented. The SEAR 002, Andrea Necchi presented some very insightful data with a combination of sacituzumab govitecan plus pembrolizumab in the neoadjuvant scenario, around 41% of pathological complete responses, very promising. Abemaciclib, Bisoy-Faltas, presented the data of abemaciclib, a CDK4, CDK6 inhibitors as a neoadjuvant treatment for patients ineligible to receive cisplatin. Only 16% of pathological complete responses, but probably very nice translational data showing that probably abemaciclib as a maintenance treatment after EV-Pembro could potentiate the activity of EV-Pembro. So far, let's see. Chinese data, very nice data, from the combination of a novel antibody-drug conjugate targeting Nectin-4 with a payload of MMAE, so the same payload, the vedotin of enfortumab vedotin, in combination with toripalimab in first-line metastatic urothelial carcinoma, is showing data of 87% of responses. This is really impactful and amazing. So probably the bar of activity in terms of responses of novel antibody-drug conjugates plus immunotherapy has not been reached so far. We have still room for improvement in terms of survival. And in the non-muscle invasive scenario, this is a landscape that is evolving very rapidly. It is changing. We saw a recent publication in Nature Medicine about the CReST trial. Sasanlimab, subcutaneous PD-1 inhibitor in combination with BCG, is impacting in the primary endpoint of event-free survival. And Tom Pauls presented the update data in the subgroup analysis of patients with carcinoma in situs with a hazard ratio of 0.58 for events-free survival, which I think this is something that it is practice changing, and probably our colleagues in the urology department will start to use these subcutaneous inhibitors, immune checkpoint inhibitors. We have seen a recent press release coming from the POTOMAC trial. Durvalumab intravenous plus BCG is also impacting in the disease-free survival primary endpoint. And more things are coming into the non-muscle invasive scenario, particularly the pretzels, the intravesical devices. So this field is going to change very, very rapidly. Probably a lot of patients will avoid or at least will delay the need for cystectomy, and definitely the use of systemic treatments in these scenarios, immune checkpoint inhibitors, systemic treatment in these scenarios will impact in the later outcomes, will impact in how we are treating patients when the tumors are relapsing. We are avoiding some relapses, but some of these patients will relapse. This is my summary for bladder, and I can't say more and I can't remember more. In kidney, well, much less data has been presented. Amazing, and for me, it's every time that I see this data, I'm impressed. The 9 years median follow-up of the CheckMate 214, nivo-ipi versus sunitinib, and 9 years after, we still see that there are patients that are alive, and around 40% of the patients are still alive after 9 years of median follow-up if the patient responded to the initial treatment with nivo-ipi. This is amazing. Unfortunately, no biomarkers can help us in daily practice to predict who these patients will be. The activity was not only seen in patients with intermediate and high risk, but also for patients with favorable prognosis. So we urgently need biomarkers in this scenario. Other small trials like the combination of sasanlimab plus nivolumab in the first-line setting are really promising. Data are pretty similar to cabo-nivo, lemba-pembro, axi-pembro. I think these data are coming a little bit late. Updates of the belzutifan, HIF-2 alpha inhibitors, the LITESPARK-005, LITESPARK-004 in patients with VHL, the von Hippel-Lindau syndrome, or patients with renal cell carcinoma, clear cell renal cell carcinoma, were updated. The data are pretty consistent. There is a subgroup of patients that are really benefiting from the use of these new agents, belzutifan. And also Tony Chori presented another HIF-alpha under development in combination with cabozantinib, casdatifan, showing very nice and very insightful data. Once again, they don't really seem better than what we can get from cabo-nivo, lemba-pembro, or belzutifan plus clavo. The differences are the nuances in the mechanism of actions or the safety profile of the combination activity in between belzutifan and casdatifan are really small. I don't see if we will be able to differentiate these trials in these agents in daily practice. Updated data from the KEYNOTE-564, the use of pembrolizumab in the adjuvant scenario, were also presented. The activity was consistent with a longer follow-up. Naomi did a wonderful presentation. So this is practice changing? No, because we have already added and incorporated pembro in the adjuvant scenario, but this is reinforcing the indication of these drugs into daily practice. So this is my summary, Michael. Joshua, I cannot do more. Sorry about that.
We're so not needed, Josh. Enrique should just take over the podcast. I think he'd be much better at it.
You can also do breast, right? No, that was brilliant. I was trying to keep track of every single trial under the sun that you mentioned, and I have a page worth. Michael, did you have any questions? And then I can ask a couple if you wanted me to.
I think I can just tell that you are just bursting with questions, Josh. So, in the interests of keeping this somewhat concise on our end, why don't we just try and get the most out of Enrique with your questions?
Yeah, no. I mean, I felt like my thought process has sort of got distracted by the next trial, so that's probably part of the issue. So, I guess to focus on the big stuff, the NIAGARA trial with the ctDNA positivity is quite an interesting thing at baseline, and whilst it might not be prognostic, it might be predictive of responses, and we saw it a little bit in the breast cancer space, sort of the use. Like it's actually becoming not right now, but I feel they're trying to position ctDNA in a way that might actually help in decision making, and I think that's always been the limit with this particular tool. We can do ctDNA, and like you've got positivity, you'll probably recur, but we know nothing else, right? It's not really a face. I mean, I don't know what it's like in Spain, but ctDNA testing, is it expensive where you guys are if you're doing it off trial?
Absolutely. We have the platform of Signatera. This is what we are really using right now, but we are just at the beginning of the ctDNA detection. I envision that soon we will have other platforms. I wouldn't say better, but I would say from a logistic perspective and from the cost perspective, more affordable than Signatera. Today I have a patient that is coming to my office just to pick the sample, the blood sample for a Signatera, and this is a patient that I use the ctDNA because the patient refused to do cystectomy. My only way to convince the patient that he should or maybe shouldn't do the operation was to do the testing, ctDNA, before the surgery. The ctDNA was negative after neoadjuvant approach. And I said, okay, guy, the probabilities of being alive would be probably more than 80% in 5 years' time.
Yeah.
I cannot promise that the tumor will not relapse. I cannot promise that if the tumor relapse, I can operate because the relapse will be only in the bladder. I cannot promise that, but this is just statistics.
Yeah.
If I am doing the right thing with this patient or not, we still don't know. The patient refused cystectomy. What can I do? Joshua, there is a huge debate out there about the definition of what we call clinical complete response instead of pathological. Pathological complete response is when you have the bladder in the table of the pathologist.
A little bit late.
This is something that we need to avoid. The thing is, can we preserve the bladder in some patients? Don't forget that cystectomy is a really mutilating surgery. It is conditioning the quality of life of our patients. And well, you are living in Australia. You know how important it is for normal people to just take a walk in the beach.
Yeah.
If you have a bag in your abdomen, this is not nice. This is condition your quality of life for sure. If you need to get your bag empty from time to time, if you need to, this is something disgusting, and this is something that the quality of life of these patients that can be potentially cured is important in the long-term run. So the definition of clinical complete responses means that before the cystectomy, if the patient is cystoscopy negative, maximum TURBT negative, magnetic resonance fusion negative, FDG PET scan negative, circulating tumor DNA negative, urinary tumor DNA negative. So probably if the patient is meeting all of these criteria, probably we can avoid to do the surgery to these patients. This is a huge debate. Of course, this is very expensive. It costs more to do all of these techniques.
Yeah, I was thinking the exact thing. I'm like,
Rather than to remove the bladder, but
Yeah.
maybe we can preserve some bladders to some patients.
It's quite similar to the way that some people are pushing for colon and rectal cancer, with basically organ preservation, and sort of, substitute colonoscopy for cystoscopy, MRI, PET scan, ctDNA. That might be somewhere that where we go for a lot of early stage cancers, but as you say, the cystectomies are particularly morbid procedures.
Absolutely. Don't forget that in the best hands, the mortality rate around the cystectomy is about 4%. So this is something, particularly for old guys or patients with comorbidities, we should try to avoid.
Which is most patients with bladder cancer, old men with comorbidities.
And moving on a little bit, the Dana-Farber trial, which I didn't get the name of, but the look of alternative histology types and the poor response to TCC. I want to talk about the Nectin-4 as an expressor for response, because I thought Nectin-4 wasn't that great of really determining how well you're going to respond. So yes, there's low Nectin-4. So were there any other explanations as to why and again, tiny cohort, right? I'm not sure how many patients were in this trial, but like a 0.16% response is shocking. Was there any sort of explanation in that particular trial about why they saw such a low response? Any sort of molecular ideas?
Well, probably sensitivity to taxane-based chemotherapy is also there. Don't forget that the payload at the end of enfortumab is a taxane. So probably sensitivity of a taxane is different than the sensitivity to platinum-based chemotherapy in non-variant histology. So probably this is one of the reasons. But another biological reason definitely is the expression of Nectin-4, which is less than in urothelial tumors. For me, this is also important. Today, there are conflicting data in terms of what is the real value of the expression of Nectin-4 for the activity of enfortumab vedotin and pembro in the first line scenario, because translational data from the pivotal trial EV302 is telling us that we shouldn't do expression of Nectin-4 to predict the activity because it is not working and because this is expressed in the majority of the patients. However, retrospective data coming from the TCGA atlas, genomic atlas, is telling us that around 17% of the patients are not expressing at all Nectin-4, and this is something that, this is something that we see in daily practice with the activity of EV-pembro. Around 15% of the patients are not really responding to EVP in daily practice. So probably this is something impacting on that. There is a German group very active in this field, Niklas Krumper, Victor Grunwald. They are working a lot in trying to do the translation of the expression of Nectin-4 and the activity of EVP. And they saw that the expression of Nectin-4 is directly related to the responses and directly related with the overall survival of patients receiving EV. Probably this is a matter of prognosis, probably it is, but definitely the activity is less. If you go to amplifications of the Nectin-4 gene, for those patients with amplified Nectin-4 gene, the activity in terms of responses is around 96%, retrospective series. 96%. You know what is the problem here? The percentage of patients with amplification of the gene is only 26%. So unfortunately, I'm afraid that the company is not really interested in selecting only this 26% of the tumors when you can treat all patients according to the labeling.
Yeah, it's an interesting area when there's conflicting data. Michael, I have another question. Unless you wanna say something.
Go for it.
Joshua,
Great.
before moving to Michael, well, you are very well related with the breast cancer field. In breast cancer, and correct me if I'm wrong, probably I'm a complete analphabet in breast cancer, so please correct me if I'm wrong. But in breast cancer, you are discussing if trastuzumab deruxtecan should be given to patients with low or ultra low expression of HER2. So
Yeah.
how the hell you can claim for the use of another antibody drug conjugate targeting at this time another epitope, Nectin-4? How the hell you can claim to treat all patients regardless the expression of the target? Doesn't make a biological sense at all.
Yeah, it's an interesting thing, and I think it's we call it the wonder drug, trastuzumab deruxtecan. It's sort of just sweeping through every cancer type. And there was, as a sidebar, there was an interesting trial looking at pneumonitis with TDXD, because there was always this sort of study, and I'll get to what you said, Enrique, but I just remembered it, that essentially if you had more than grade 1, pneumonitis, you stop. There's actually now a series which shows that if you have sort of grade 2, you can re-challenge depending on sort of a number of factors like, radiological symptoms, etc. But going more to your point, you're right. It's a really difficult thing. And I think what it's actually showing us is that these markers we have to look at response aren't the right markers. We don't know the whole picture. We don't understand the whole pathways, because theoretically Herceptin should work amazingly. It was the original wonder drug. Maybe it's just the chemo, warhead, but you could probably argue that if you found the right receptor, you could put anything there and it would be fine. You'd have no toxicity. You'd go live on a beach in the Mediterranean somewhere because you'd have that yacht, or the yacht in Barcelona. But moving to my next point, and the reason I bring this up is I had a patient who wanted this drug in Australia, or a similar drug. So the non-muscle invasive bladder cancer space, really fascinating, isn't it? BCG is, it's boring now. It's been boring for a while, but it was a good drug. And I don't know if the CReST trial was the one that's the pretzel. Is that the Johnson & Johnson trial, or is this a different one?
This is the Pfizer one. Sasanlimab is a subcutaneous PD-1 inhibitor from Pfizer.
Yeah. Because the data is incredible. The data of sort of reducing the need for cystectomies in these pretzels. It costs in Australia, if you're interested, if you want to self-fund it, it was $35,000 a dose, because I had a patient who was that keen not to have to go down the muscle cancer invasive route. Like, he was sort of Genesis, subcutaneous, wasn't responding, and then he was clear, so he didn't get it, but just, $35,000 a dose for this. But it's really interesting space. And do you think if we pick up these cancers early, maybe the whole muscle invasive won't be an issue? You just pick them up at non-muscle invasive and then you give them this treatment.
And don't forget, Joshua, that 70% of the patients with the diagnosis of bladder cancer are non-muscle invasive. So I don't know, in Australia, you are a rich country, but in a poor country like Spain, we will not be able to afford to pay this kind of new agents.
Yeah, well, the PBS in Australia is quite strict. So whilst we are the lucky country for more reason than one, we don't have access to everything, and that's probably a good thing. I think it's better to streamline. Well, Michael, I don't know if you had anything else, but I feel Enrique probably has better things to do than continue talking to us. Do you want to finish off the episode?
I'm sure that Enrique has dozens or hundreds of patients that are just as keen to tap into his wisdom as we are. But thank you so much again for coming on the show, Enrique. It's always lovely to hear from you, but to hear just how effortlessly you put everything into context. So thank you so much for coming on our little ASCO mini-series.
Thank you so much, Michael, Joshua. It's always fun to see you both.
Yeah, very good.
We're very glad, and right back at you. We look forward to having you back very soon.
Hopefully at ESMO.
Hopefully at ESMO. Sounds great. Take care.
Take care. Have a good day.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts, and much more at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.